Hello everyone and welcome to another deep dive session with Pekga, Practical EKG Academy. Today we're going to be taking a look at this rather interesting and quite frankly dangerous ECG. We're going to build up to this 12 lead view. We're going to be starting with a single channel, right? Pretty typical for us. Okay, so single channel. The only thing you can reliably pull off of a single channel, right, is rate and rhythm. Rate, again, anytime anybody mentions, the word rate, you got to respond with rate of what? Rhythm, as you've come to know watching these videos, can be a bit tricky, and you will see how tricky it can get in this very ECG. So let's get to it. As far as the rate goes, I'm going to start right here, find this QRS lying on this line just because it's easier for me to keep track of everything, and I'm going to use the 300 rule. 300, 150, 100, 75. This is 60 right here. This is a little bit closer to the 75 mark. I'm going to say that this is roughly 62 beats per minute. If I said 60 versus 62, not a big deal. Well, in this case, it might be because when things get a little dicey and you're trying to measure ejection fractions, a couple of beats can make a difference. So in this case, I'm going to try and refrain from being so nonchalant. If you ever want to verify your rate real quick, you can do a simple verification. So this is a 10-second strip, right? There's 10-second strip. There should be 6 of these strips in a minute. So I'm just going to count off the QRSs here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 times 6 will give me 60. So what we got up here, pretty close. All right, let's keep going. The first thing that really stands out to me here is the width of this QRS. So if I zoom in here, and I'm going to be double checking this QRS, but I'm just going to kind of draw a line right here, and I'm going to say my J point is right there. And if we measure this out, we have 1, 2, 3, 4. Did I measure that correctly? Yeah, 1, 2, 3, 4, almost 5. Almost 5. So this is, I'm going to have to double check this, but this QRS is extremely wide. This is a red flag. Okay, so this is greater than 160. I'm reluctant to call it 200 here until I double check, but this is greater than 160. This is a red flag. We're going to double check that when we get to the 12 lead, but this is cause for concern. One other thing that I can tell you right off the bat is looking at this channel 2, right? When your S wave in lead 2 is larger than your R wave, you're probably going to have an axis issue. So there's the axis is off here. That, in my mind, the light went on. As far as the T wave seems to be doing just fine. We appear to have a P wave present in front of every single QRS. So this could be a normal sinus rhythm. I'm going to take a look at this right here. Actually, this is not a bad spot to measure this QRS. Let's see here. 1, 2, 3, 4, 4.5. So yeah, 170, maybe 180 milliseconds. Oops. 170. What is wrong with me? There we go. 170, maybe 180 milliseconds for the QRS, but I'm going to have to double check that. That's extremely wide. Although the reason I zoomed in here, I wanted to take a look at this PR interval. And this PR interval, it appears to be roughly 190 milliseconds. So everything is borderlining or is being extremely wide here. Let's keep going. So far what so far what we have gotten here is we have a rate of 62 beats per minute, right? The QRS is extremely wide, And the rhythm itself, it appears to be normal sinus rhythm. Again, we cannot make that confirmation until we see a couple of more channels. So let's get to it. Okay, welcome to the 12 lead, right? Oh boy, yeah, the QRS is extremely wide. I'm gonna double check the QRS right away because I'm very, very interested in the width of the QRS. So I'm gonna say the QRS starts right here. 1, 2, 3, 4, 4.5. 4.5 will give us, will give us 180. Right? 4 times 4 is 160, and then another box would have been full 200 milliseconds. Half of that will give us 180. This is a giant red flag. Okay, so we have our first red flag, and that is the QRS is 180. But let's go back to basics, right? What stands out? The QRS stood out to me. I'm going to go back, drop the level of excitement, if you will, and I'm going to work my method here. So the first thing I want to see is if the P waves are present before every single QRS. They are in the strip that we have been given. Now, in lead 1, it appears that P wave indeed is upright. In lead 2, it is upright. In lead 3, it appears to be upright. In AVR, here it is. It's inverted. So this indeed is a sinus rhythm. How normal it is. Normal typically implies that the rate is between 60 and 100, but I have a hard time calling this normal. Okay, let's keep going. As far as the PR interval, we are borderline first degree, but I'm going to push that aside for a second. The QRS is extremely wide. ST segment, I do see changes here, right? I'm going to come back to those in just a moment. Otherwise, the T wave, with the exception of what I've labeled on here, the T wave appears to be okay. Okay in the sense that it's not, in other leads, it's not taking a weird morphology. It's not doing anything funky outside of the leads that I have labeled. But I'm going to come back to that. Okay, so axis. I want to take a look at this axis because this is screaming at me right now. Anytime you have a negative axis, a bigger S wave in lead 1, that immediately is, in my mind, cause for concern. But here we have it in lead 1, in lead 2, and in lead 3. When we go back to our axis finder, right, look at this. Lead 1, lead 2, lead 3. We're talking about extreme axis deviation. So whatever is going on in this heart, the signal is being pushed. The overall axis of depolarization is going in the opposite direction. So something is happening in the heart that the axis of depolarization is being pushed away from its typical angle of propagation, which would be closer to 60 degrees. Here we're almost in exactly opposite direction. In fact, let me double check something. Yes, look at AVL here, right? So taking a look at AVL, AVL is isoelectric. So there's the R wave seems to be equal to the S wave, meaning whatever's going on above and below this axis of depolarization, it's being balanced out. Now, for me, that is useful because I can go over to the hexaxial system here. I can find lead AVL, draw a line on it, and now whatever's going on, it's going on exactly perpendicular to it, which would be lead 2. We know that lead 2 is negative, so whatever's going on, it's moving in exactly this direction. that gives us negative 120 degrees. So we have, going back to our ECG, we also have extreme right axis deviation. This is another giant red flag. So we have a very wide QRS, we have extreme right axis deviation. At this point, if you as a technician or whoever's taking this, a physician, it doesn't matter, whoever's doing this ECG, performing this ECG, right? There's a tendency to kind of freak out in front of the patient or maybe have an expression on your face. Try to reserve that. You don't want to scare the patient at this point. But this is alarming, right? So we have what appears to be normal sinus rhythm. The QRS is extremely wide. We do have extreme right axis deviation, big red flag. Let's keep going. Okay, AVR is inverted as expected because we're dealing with extreme right axis deviation. So AVR, instead of the QRS pointing down, it's pointing up. Okay, now we're going to shift. Our planes. So we're going from our frontal plane to our transverse plane. We're shifting over to our precordial leads, right? And actually, it's worth taking a look at this. So this is what I'm talking about for those of you who are new and watching these videos. We're shifting from this frontal plane, right? Looking at Eindhoven or limb leads and augments. We're switching over and we're going to be taking a look at the precordial leads, right? Or the transverse plane. Now, what I'm looking for over here is R wave progression. This is what a healthy or typical or expected normal R wave progression should look like. Small R wave in lead V1, slowly increasing, and then we have a transition from a predominantly negative to a predominantly positive QRS somewhere between leads V3 and V4. That's what I'm hoping to see. However, that is not the case on this one. We have an immediate huge R wave. It's very typical of a right bundle branch block, which is exactly what we do have here, right? We have an extremely wide QRS. We have right bundle branch block morphology. We have a slurred S in lead 1. We have a slurred S in lead V6. We do have right bundle branch block. Okay. Now another thing, with right bundle branch block, sometimes it is difficult to figure out if you have right ventricular hypertrophy. Right ventricular hypertrophy is significant. Of course, any hypertrophy is significant. So I'm just going to take it down to basics. One of the quickest ways you can tell if you have right ventricular hypertrophy if we did not have right bundle branch block would be if you were to measure the R wave in lead V1, and if this was greater than 7 small boxes, that immediately sets off a yellow flag, if you will, and you have to double check if indeed you do have right ventricular hypertrophy. Same thing for leads V5 or V6, whichever one has a deeper S wave. If the S wave in lead V5 or V6 is greater than 7 small boxes, that's a yellow flag. You need to double check right ventricular hypertrophy. And by double checking, you can do that on the ECG. We're going to switch over to Sokolov criteria. Here in Sokolov criteria, essentially, well, not essentially, but specifically it states that if the R wave in lead V1 and the S wave in either V5 or V6, wherever it's larger, if those two numbers, when you add them up, are greater than 10.5 small boxes, you do have RVH. So let's measure that out. Here, I'm just going to take one that's clean here. So This is roughly the baseline, and here we have 5, 6, 7, a little over 7. I'm just going to call it 7 for the time being. So right there, right, that's that is good enough to start investigating right ventricular hypertrophy. And then when we take a look at V6 here, here's our baseline, right? And then we have what do we have here? Well, actually, I could have measured it right here. It's just a little easier to measure. So here we have 5, 6, 7, 8, 8.5. 8.5, right? So I'm going to call this 8.5. If I called it 9, I could have done this. I kind of cheated up here a little bit. I stole half a box. But in fact, let's do that. I'm going to call it 9. So when we add these two numbers up, right, 9 plus the R wave in V1, 7, this gives us 16. Sokolov criteria says that you have RVH if the addition of those two numbers is greater than 10.5. So this indeed all of a sudden becomes, confirmed RVH. Now, typically with ventricular hypertrophies, other tests have to be done, like echocardiogram, perhaps an MRI, so on and so forth. But in this case, there's such overwhelming information pointing us or confirming RVH. For example, one of the things that confirms RVH is the presence of S waves in leads 1, 2, and 3. So this is known as S1, S2, S3. That is a secondary confirmation of the RVH. So all of a sudden RVH is, 100% on the table. But even further than that, going back to these T waves, when we have inversions, T wave inversions in leads V1, V2, and V3, this is a what's known as a strain pattern. So this would be RV, right ventricle strain, right ventricular strain. So right ventricle is having a hard time performing its normal functions. And this is the signature that it carries: inversions and ST depressions in leads V1, V2, and V3. And we do have a slight ST depression. If we take a look at this right here, this is your baseline. There's a bit of a depression, almost, see right here, almost one small box. It's not much, but it's enough to confirm RVH. So far, we have extreme right axis deviation. We have right bottom branch block. We have right ventricular hypertrophy. We have an extremely wide QRS. If you don't know what you're looking at, you're looking at the ECG for the first time, and you just labeled all of this on the ECG and you handed it over to somebody, they should be alarmed. Oops, they should be alarmed. And the reason is because what you're looking at here is what's known as Tetralogy of Fallot, TOF for short. Now, we're going to be discussing what this is, but I want to point something out. This is what we saw on a 12 lead, right? So you have 12 channels, and we were able to pull all of this information, all of the out of this ECG, as compared to if you were just looking at a simple single channel, right? Looking at this single channel, none of that information that we saw on the 12 lead would be available to you. Now, if you're a random person just looking at ECG videos on YouTube, and you have an Apple Watch or one of those little gizmos that measures your heart rate and gives you a short little ECG, take notice of this. Sometimes you might get a little freak out over something, or ask for a whole lesson on cardiology based of one single strip. There's very little information that can be pulled off of a single strip. And look at this. Here we were trying to confirm rate and rhythm versus all of the information that we got off of this 12 lead. So huge difference, right? Okay, now I want to discuss this Tetralogy of Fallot. Okay, so what we have, let me find the heart. Where's the heart? Okay, so this Tetralogy of Fallot. What happens in this Tetralogy of Fallot, kind of difficult for me to pronounce. Actually, first time I heard that term, I called it Tetralogy of Fallout, and close in pronunciation, but in my mind it was Tetralogy of Fallout, and it stuck with me almost until this very lesson. But essentially, when human heart develops, the septum within the heart develops in several different portions, if you will, and over time they merge together, and you get this nice strong wall that separates the right ventricle from the left ventricle. Now that doesn't always happen according to plan, and let me go back to the ECG here. Okay, I'm going to have to delete this. Sorry, guys, just 1 second. Okay. So Tetralogy of Fallot is a congenital disorder. Congenital meaning it happens during development. So as a person develops, right, as a human being develops, something is not right, and it doesn't get corrected. So what happens in this particular instance is the ventricular septum is defected. There's a hole in the septal wall between the right and the left ventricles. So going back to a trusty little picture, what that's saying is there's a hole right here. So one of these gaps, as it's developing, it doesn't close. Now, what happens as a consequence, right, in your right ventricle, you have oxygen poor blood. So this is all the blood that's coming back via vena cava, right? It's bringing back deoxygenated blood into the heart, and now that blood can go across. Well, okay, I'm getting ahead of myself here. It's not really that the blood is getting across. Let's go to the second portion of this Tetralogy of Fallot. So the second segment of this Tetralogy of Fallot is we have right ventricular outflow tract obstruction. So there's a narrowing of the path of the right pulmonary artery, otherwise known as stenosis. Third component of this is overriding aorta, so access to both ventricles instead of left ventricle only. This congenital syndrome, if you will, or pathology, is related to something that was people used to call these kids blue babies, and I'll explain in a moment why. They actually did look blue. And finally, to complete the tetralogy, right? Tetra meaning four, we typically have the presence of RVH, or the enlargement of the right ventricle. So there's a thicker muscle. There's more muscle present there. So going back to the cardiac anatomy, what happens to paint you a more complete picture, as this heart is developing, aorta doesn't, the opening to the aorta, if you will, it does not develop properly, and it kind of overlies over the septum, And now it has access to this oxygen poor or deoxygenated blood, but also oxygenated blood. Now, aorta takes the blood, right? It's the main artery, takes the blood away from the heart, but it's oxygen-rich blood. So this is feeding your system. However, now it's feeding both deoxygenated and oxygenated blood. As a consequence, babies, while they're developing, because of this oxygenated poor blood, they used to look blue or bluish. They had a bluish hue. It's kind of a fascinating, really morbid thing to look up, but feel free to research it a little bit. It is, it's an impressive phenomenon, really. Now, one other thing that happens, so we have aorta that lands not only in the left ventricle, right, but it lands on the septal wall, and it has access to both the right ventricle and the left ventricle. As a consequence, it also strains or puts pressure on this pulmonary artery, right? So arteries take blood away from the heart, right? Pulmonary just means to the lungs, so it's taking blood away from the right ventricle to get oxygenated, so it can come back and feed everything in your system. Now, what happens as a consequence, because there's strain from aorta, right, on the pulmonary artery, what happens? Let me just get a wider brush here. Let's do a really wide one. Okay. What happens is the right ventricle is working really, really hard all the time, and this muscle thickens. Okay, not the best color to choose for this. Okay, there we go. This muscle thickens. Okay, this muscle thickens, and it gets so thick that first of all, it changes the axis of depolarization because there's so much mass instead of what it's supposed to be there. Second of all, there's a lot of strain, there's a lot of pressure exerted on the ventricle itself. I mean the empty space. No, well, it's not empty. It's full of blood, but on the space in between the walls of the right ventricle. So this is a very high pressure system where normally it was not. And let me see if I can paint a better picture here. Yes, here we go. So on the left here, right, we have what a typical heart would look like, right? No, or typical, far-fetched, but no right ventricular hypertrophy, right? So this is your axis of depolarization, this kind of purplish hue down here. It's going down into its, what do you call it, bottom right or bottom left quadrant. However, when this increased mass, and I hope you can tell the difference here, right? Look at the thickness of this wall here, right? Look at the thickness of the right ventricular wall in this scenario, or in this example over here. And that sheer size of the muscle forces the axis of depolarization to shift to the right. So see this axis shifted from here over here. Okay, that's a telltale sign of right ventricular hypertrophy. That's one thing that I forgot to mention on here. We do have extreme right axis deviation, which is a supporting element when it comes to right ventricular hypertrophy. Okay, so Tetralogy of Fallot. And by the way, here you can kind of see expected differences. See V1 and V2, and see what it looks like when you have right ventricular hypertrophy. Now notice these are not wide. Okay, you don't have right bundle branch block just because you have right ventricular hypertrophy, and also vice versa. Okay, so anytime you have a large R wave in lead V1, please double check what it is that you're looking at. I'm going to move this up for just a moment, and I want to discuss something else. I'm going to come back now to the QRS. Well, let me back up even further. I want to discuss the right bundle branch block. So in Tetralogy of Fallot, right bundle branch block is not a characteristic of Tetralogy of Fallot. What we have here is this person probably, they had this syndrome, they had this pathology, and at some point, well, let me go back to the heart. At some point, there was a procedure done in order to relieve the strain on the pulmonary artery. Now, that's a complicated procedure. I'm not going to get into that in this video here. However, what happens is during that procedure, the right bundle branch of his Purkinje system is thin. It's a lot thinner than the left bundle branch, and it gets damaged. It gets severed. It gets severed during this procedure. It gets damaged. So what happens on the ECG is we see right bundle branch block. So if you have somebody that you suspect they have Tetralogy of Fallot, but they also have a right bundle branch block, you immediately can suspect that they have had a procedure done to correct, to help with this Tetralogy of Fallot, with the pathophysiology, right? So there was a procedure done, and as a consequence, there is now a right bundle branch block present. Now here comes the really scary part, if you will. When looking at this QRS, studies have shown that when the QRS is greater than 180 milliseconds, there is a drastic increase in possibility of ventricular tachycardias, and there's a drastic increase in risk of sudden cardiac death. So this is a life-threatening scenario. Okay, let me do this one more time. Single channel, right? Rate and rhythm. If you saw this, you would say, okay, this looks like normal sinus rhythm, right around 60 beats per minute. The QRS is wide. Thank you. Have a nice day. Look at the difference here, right? So I deleted all the jibber jabber I had on there earlier, but here we're dealing with Tetralogy of Fallot, and you just found out that if the QRS is greater than 180 milliseconds, which in this case it's right at 180 milliseconds, there's an increased chance of ventricular tachycardias, there's an increased chance of sudden cardiac death. Like I said, an interesting ECG. I kind of don't like doing interesting ECGs because I know that there's a person behind this ECG that has to live with this. But it is important for us to recognize such rhythms and such things on an ECG. So next time you see, excuse me here. So next time you see right bundle branch block, don't ignore it as right bundle branch block, no big deal. Start taking a look at your criteria for right ventricular hypertrophy. Next time you see, extreme or just right axis deviation here, technically, when it comes to the axis, anything greater than 110 degrees is significant. And by significant, I mean it's a red flag. But here, this went to negative 120, so quite different. So details matter. Details matter. Just because this looks kind of like a slow, regular rhythm, right? 60 beats per minute, slightly wide. You're not seeing any ventricular tachycardias. There's a little bit of T-wave inversion. I guess that's okay. Don't let it be okay. Investigate, question, and learn, right? We all had to start somewhere. So if you're watching this video and you are new to the ECG game, do not despair. We all had to start somewhere, and we all had to learn bit by bit, and commit some of this stuff to memory. So anyway, I'm getting off on a tangent, so I'm going to stop right here. But I want to thank you guys for joining us. There will be a link to the rapid version of this video in the description down below, so feel free to check that out. And once again, thank you, and we'll see you.